Hello, my name is Forrest Arnold, and I'm the PI for an RSV vaccine study here at U of L Division of Infectious Diseases. And so today I'm sharing about the study to hopefully answer some of your questions. If it generates new questions, I'm going to have an email at the end, and we want to hear from you. Also, it may make you more comfortable on the day that you come in because you'll have been better informed about the study and the benefits of participating. So I'm going to share my lecture at this time and tell you about our RSV vaccine study. So Stephen Goatee is the Director of Research, Don Balcom is our nurse practitioner, and Danya Sheikh is also working with the study, and the four of us will have live question and answer sessions that we will do. And if you can't make one of those, we'll record them and post them as well. And at any time, you can ask questions that we'll post answers to online. So today, I'm going to try to answer a few questions. Why RSV vaccine in adults? Because we know it's a childhood illness. Or I'm going to go over the RSV natural course and outcomes. I'm going to give an overview of this vaccine study. I'm going to report of the thrombotic thrombocytopenic syndrome and the adenovirus vaccines, mainly the COVID vaccine, and how the RSV vaccine works. So RSV year to year, as you can see, it has a season just like flu season, and we know that a lot of children, especially infants, get RSV. The bright purple is the area where children and infants get RSV, and then age 5 to 64 is a huge age range. It's actually not that many people make up the lighter blue, and then the lightest blue are those age 65 and older. So each year we see a portion of patients who are older who get RSV, and that would be you. Now, what happens when you are not around people? You wear a mask and you wash your hands. You nearly eliminate the season, as it happened after this season during the COVID pandemic. So let's look at the RSV in two countries. The first is England and the second is the United States. And you see that almost half the cases are in 0 to 17-year-olds, and then about a third are in 18 to 64, and a quarter are in 65 and older. And what happens to those people, of the people who are hospitalized or die, which is about a tenth, most of them are 0 to 17. And then there's a smaller chunk, 18 to 64, and nearly a third are either hospitalized or die who are 65 and older. So it's kind of on either end of life spectrums, in the very young and the very old. I'm not calling 65 very old, but you get the idea. So here's the groups that we're talking about: grandparents and the grandchildren. So one of the questions is that we have answers to is who is giving this infection to whom? So if the adult gets the vaccine, will you prevent it to the child? Yes, but the child is also giving it to the grandparents. And so it's important to help break that cycle. RSV is not like influenza where you might get it once in a season. You could get it more than once in a season. So overall, let's look at RSV just in older adults. 2 to 6% of people have mild symptoms of all those who are over 65. And that's primarily upper respiratory tract symptoms: nasal congestion, runny nose, sore throat, and a mild cough. Then the next group is a little more serious. Those people visit their primary care doctor or go to the emergency department. They have moderate to severe symptoms requiring some medical attention, and they have a mix of upper, lower respiratory tract symptoms with cough, wheezing, shortness of breath, and fatigue. And then the smallest portion are actually admitted, and they have lower respiratory tract symptoms, and they have complications including pneumonia, and they may decompensate, and especially if they have comorbidities like chronic lung or heart disease. So let's look at how this pans out. This table I put here is too small, so let's blow it up. And what you'll see is each year, the breakdown of those who are hospitalized. As you get older, you're actually more likely to be hospitalized because so many children and younger adults don't get hospitalized. And so this is the case. The green is the total, which means an average of all the ages. So as the age groups are recorded here, it's the people who are greater than 85 who are most likely to be hospitalized. So the people for our study include the dark gray, yellow, and blue. Now, these are the years you can see each season. And what happened in 2018-19 was that we had an epidemic of infant RSV, and we experienced that in Louisville. The Cosair Hospital was full, and so that can happen at times, and there were even more infants hospitalized than adults that year, and there was a lot of older people. Okay, so if we look at RSV overall, the epidemiology is 2 to 5 million cases per year. Each year is about 3 to 7% of healthy older adults and 4 to 10% of high-risk adults, those who have comorbidities. Those who are outpatients, 89 were symptomatic with several physician visits and ER visits, as you can see there. Then of those who were hospitalized, it was 177,000 with a length of stay of 4 to 12 days. And of those, 15 to 35%, up to 62,000 people, required ICU admissions. And some of those, 85 to 100%, required mechanical ventilation, the breathing machine. So if that were the case, your length of stay was lengthened from 6 to 18 days. And then finally, 14,000 deaths occur in people over 60 due to RSV. And I think this is one of the strongest arguments for getting an RSV vaccine in adults. But as you'll see, there's another benefit, and that is just preventing the pneumonia. So it'd be better to get RSV and get a cold than get RSV and get pneumonia, which has worse outcomes associated with it. So if you get hospitalized and need ICU care, your chance for mortality is up 37% compared to those who are not in the ICU. So there's already been a phase 1 study performed. It has 72 people, and the purpose was to ensure the safety of the vaccine, and there were no serious events. 12 people had injection site tenderness, redness, swelling, and that was recorded. Then there was a phase 2B study that was similar to what we are doing. There were about 5,000 to 6,000 participants, and that was mostly in people 65 and older, and it was 80% effective, which is good. Now, what type of study are we doing? We're doing a randomized, which means we're going to pick people when they come. They will randomly be selected for a placebo, so it's placebo controlled. And double blind means the person getting vaccinated does not know which group they're in, the vaccinated group or the placebo group, and the person giving the vaccine doesn't know if it's placebo or if it's vaccine. We do have pharmacists, however, who are unblinded, so they can keep track of who actually is gets the placebo and who actually gets the vaccine. When we did the COVID vaccine, we did eventually the sponsor had people get the COVID vaccine of the placebo people when it became more standard of care. RSV vaccine is not standard of care, but if it were to become that way during the study, then we would have the people who receive the placebo get a RSV vaccine. Okay, this is an adenovirus vaccine, and so I'll tell you what pre-F means towards the end of the talk when we go over the mechanism of action, but it is similar to the COVID vaccine. And the purpose of the vaccine is to prevent lower respiratory tract disease caused by RSV, and it's for people 65 and older. The title of the study, the formal title, is those aged 60 and older, but the sponsors already filled the slots for 60 to 65, so now we were filling those 65 and above. So the primary objective of the study is to prevent lower respiratory tract infection due to RSV. And there's some secondary things that are going to be recorded. One of them is to prevent acute respiratory tract infection, reduce symptoms of an acute respiratory tract infection, evaluate safety, and evaluate immunogenicity. And what that means is to measure the body's immune system to the RSV vaccine, and the easiest way to do that is to measure antibodies. So the inclusion criteria is short. You need to be 65. You can have comorbidities, but not severe ones, and you can't have had a fever in the last 24 hours. So if you did have a fever in the last 24 hours, you would be excluded and need to reschedule. If you had a serious comorbidity, you would be excluded, whether it's end-stage renal disease, unstable cardiac disease, Alzheimer's, immunodeficiency of any type, whether it's cancer or HIV, cancer within 5 years unless mild skin or carcinoma in situ. Then if you're acutely ill, again, you need to reschedule and come back over your acute illness. And if you have a history of TTS, which is thrombotic thrombocytopenic syndrome, or HIT, which is heparin-induced thrombotic thrombocytopenia, heparin is a blood thinner. So if you've had other vaccines in the last 28 days, then that would be, you would need to wait. There's 5 live vaccines, and if you've had those in the last 28 days, then you'd have to wait. Those include intranasal influenza. I don't think that'll be anybody because flu season's over. Measles, mumps, and rubella is MMR. Typhoid, varicella, which is your chickenpox vaccine, and yellow fever, which you might get if you've been traveling, but just in the last 28 days. You also should not have had a COVID vaccine from Johnson & Johnson or AstraZeneca, which they have in England, within 28 days. And if you've had any vaccine in the last 2 weeks, you would want to be enrolled after the 2 weeks is over. So the study design is basically for every 2 people that get an RSV vaccine, 1 person will get a placebo. And again, that'll be randomized. So the company wants to make sure that the proportions of people in Louisville that are present are also included in the study, and it's not just one population over another. So the selected lower respiratory case definition is that there's a laboratory confirmation of RSV vaccine. And then if you get sick during the study, that's what we want to record. And so if you develop a cough, shortness of breath, you're coughing up phlegm or wheezing, then that will be a time you'll need to record that. So at home, you'll do a nasal swab on day 2 or 3 and another one on day 5, and every 2 days until your symptoms start to come down. So this curve is an example of somebody who gets sick. You know, it takes a few days, 3 days to get sick, then your symptoms kind of stabilize and you get better after a week. So you can see where this nasal swabs were done at home for this person. There'll be a device, an app set up for your phone so you can record your symptoms, and then we'll be in touch that way. So when we talk about thrombotic thrombocytopenic syndrome, I wrote it out here so you can see what this mouthful is saying. Those are people who have low platelets but are clotting, which is kind of the opposite. So it's really doesn't physiologically make sense, but it's a reality because it happens. The COVID vaccines were associated with this with adenovirus, 1 out of 250,000 people. They also recorded it with mRNA vaccines, and that was 1 out of 50 million. So it really isn't associated with the mRNA vaccines. And so what we understand is that 1 out of 50 million is the baseline value just in society in general. If you were to look at people before COVID vaccines, probably 1 out of 50 million got this unusual syndrome. And then with the RSV vaccine, there's been about 16,000 people, maybe it's up to 19 now, and we've had no cases of this condition. So that's good. Now the mechanism of action, I want to go over this vaccine. This is an RSV, that's an RNA inside the cell. And then the thing of interest here is this fusion protein. So when RSV divides, just like influenza, these outer structures will change a bit, except for the fusion protein. And so this fusion protein is a prime target for a vaccine because you can make it for the fusion protein and trust that it's going to keep working after the RSV might change and you are exposed. So here is an altered adenovirus that cannot cause illness, that they stuck a piece of the RSV inside the cell. This is not enough RSV to infect somebody with RSV. And so what it does, though, is it delivers the RSV piece into a person. Here is an example of the vaccinated cell. And so once inside, it comes out of the adenovirus, and then that piece is transcribed and translated and eventually expressed on the surface of the cell. And so when that happens, it can directly stimulate the immune system, B cells, to make antibodies. In case you actually do get infected with a real RSV, you'll have antibodies to bind to the RSV. There are other ways. Indirectly, the pieces can be presented by antigen presenting cells and eventually stimulate the B cells that way. And so again, it will increase the amount of antibodies you have to RSV in case you're actually infected. So here is the RSV that is now being attacked by all these antibodies that somebody has received because they got the vaccine. And then here's an example of a couple groups of people. The flat line down here are those who did not receive the vaccine. They got placebo, and then they measured their antibody in the beginning, and they measured their antibody later, and you see they didn't generate any antibodies. But those who did get the vaccine, they measured their antibodies in the beginning, which were low, and then later, 29 days later, they measured their antibodies and they were high, showing that the vaccine stimulated the people's bodies to make antibodies. And here is our gentleman who is ready to be enrolled in our study. This is actually a Google photo, so don't worry, I'm not breaking HIPAA. And if you have questions, I want you to email them to us at uvlvaccinestudy@louisville.edu. And we also, if you were contacted about this study, you probably got a link to our study, which is this long link here. But also you can just directly email us if you have questions, and you can respond to the email you got. Also, we will post times that we will have live question and answer sessions where we can go over some of this again or clarify your questions, and we hope to see you down here at the Division of Infectious Diseases at U of L.